Hi, everyone. So my name is Megan Howlett. I'm a fourth-year psychiatry resident at the University of Calgary, and I've had the privilege of working on my research project with several team members from neurology, Dr. Davide Martino, Dr. Christelle Niles, and Dr. Tamara Pringsheim. And I'm here today to talk to you about the study that we completed, which was the prognosis of rapid onset functional tic-like behaviors, a prospective follow-up over 6 months. And so some objectives for what we're going to talk about today includes reviewing the characteristics of functional tic-like behaviors or functional tics and what the difference is between primary tic disorders, reviewing the social contagion phenomena of FTLBs and how this is related to the COVID-19 pandemic, as well as review follow-up data for adults and adolescents with functional tic-like behaviors here in Calgary. So since the onset of the COVID-19 pandemic, clinicians around the world have become aware of a rising phenomenon of functional tic-like behaviors. And this is at various neurologic centers and movement disorders clinics across the United States, United Kingdom, Australia, and Europe, in which they've become aware of a rising phenomenon of functional tics. Previously, this would be a rare phenomenon, but did occur, but there appears to be quite a surge in the number of referrals received related to functional tic-like behaviors over the course of the pandemic. And so what are functional tic-like behaviors? Just to review what a tic is, it's a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. And tics can be simple or complex in nature, and they can be motor or vocal in nature. And so an example of a simple motor tic would be eye blinking, versus a complex motor tic would include something like a hand gesture or something more complex, utilizing more muscles and body parts for movement. Versus a simple vocal tic would be something like throat clearing or sniffing. And complex vocal tics are typically vocalizations of syllables, words, or phrases. And complex tics are rarely seen in the absence of simple tics. So typically there is a progression from simple to complex for both motor and vocal tics. And so functional tic-like behaviors represent a distinct subtype of functional neurological disorder or conversion disorder in the DSM-5. And this is thought to predominantly occur in adolescents and young adults. And the majority of patients in North American samples have been assigned female at birth, but a German sample showed more equal gender distributions. And so to compare a little bit between a primary tic disorder, for example, Tourette's disorder, which would have both motor and vocal tics, versus functional tics. So with Tourette's disorder, there's typically a gradual onset of symptoms that occur and evolve over months to years. The age of onset is typically quite young, 4 to 6 years old, with the mean being about 6. And there's a peak severity by 10 to 12 years of age and a waning course during adolescence. And this is as per the DSM-5 as well. As well with Tourette's disorder, there's typically progressions that occur, such as the rostrocaudal progression, which means that symptoms occur typically in the face and head first, then moving into other parts of the body and extremities. As well, we talked about already, there's rarely complex tics in the absence of simple tics of the same varietal. And so we would typically expect a progression from simple to complex in both motor and vocal types of tics. As well, Tourette's disorder tends to be more common in males, young males. And as we'll see, there's quite a bit of difference between what we're seeing in the functional tic-like behavior population. With these individuals, the symptoms are typically happening with a very rapid onset. The escalation can occur to peak severity within hours to days. There's a later age of onset, typically in adolescence and even young adulthood, which would be very atypical for Tourette's disorder or other primary tic disorders. Functional tics do not follow that typically expected rostrocaudal or simple to complex progression. Many present initially with rapid onset, complex motor and vocal tics, including high levels of coprolalia. And so coprolalia is the uttering of socially unacceptable words, obscenities, slurs against racial or religious groups. They're abrupt and lack the prosody of similar inappropriate speech observed in human interactions. And so this is actually quite a rare phenomenon in primary tic disorders, but we see a high proportion of coprolalia in functional tics. As well with functional tics, these can be large amplitude movements, and they may be directed at other people, such as hitting a parent or another individual, and may also be self-injurious, which is less common with primary tics as well. We mentioned the female predominance in our Calgary sample, and there's often an absence of a family history of a tic or Tourette disorder. Additionally, functional tic-like behaviors had a higher Yale Global Tic Severity Scale total tic and impairment score than would be expected at initial assessment for Tourette's disorder. They were also more likely to meet the clinical threshold for a comorbid anxiety disorder or major depressive disorder. Many who presented with functional tic-like behaviors were actually unable to attend school or work. Some were unable to perform their activities of daily living due to these tic-like behaviors being so disruptive to functioning. And many presented to emergency services, specifically at the Alberta Children's Hospital. Both Tourette's or primary tic disorders and functional tic-like behaviors can have a premonitory urge, or that sensation of a building urge, and that there is a release from having the tic-like behavior. This is about 50% of those with functional tic-like behaviors may endorse having a premonitory urge, but it is common in both disorders to have a waxing and waning course and be suggestible and distractible. So how do functional tic-like behaviors relate to social contagion phenomena, and especially during the COVID-19 pandemic? So there were theories of the magnification of the number of referrals for functional tic-like behaviors being related to mass hysteria and potentially social contagion, specifically spread from person to person through social media. And some examples of why this theory came to be are that some of the symptoms of complex vocalizations were common expressions seen in those who were social media influencers with tic-like behaviors, as well as coprolalia. One example of a common expression that occurred in many individuals who followed certain social media influencers and they themselves experienced or portrayed this vocalization would use the word beans or have the word beans in their tic-like behaviors, which is not typical of a primary tic disorder and wasn't typically seen until this surge of phenomena during the pandemic. Most individuals also reported watching people with tic-like behaviors on social media, sometimes in the immediate time period before their onset of behaviors. The patients at times identified with these social media exposures. With some of the younger children, social media use was only disclosed after careful questioning. But some external factors that may be related to why these videos are related to these types of behaviors occurring include having an instilled belief that the tics may catalyze peer acceptance or even popularity, as many of these social media influencers have thousands, if not millions, of follows and followers. The exposure to tics may be a plausible trigger for some of these patients based on a disease modeling mechanism. Although this was reported in all of the patients seen in the initial case series here in Calgary, this was not seen at all other centers, and thus social media exposure should not be considered a prerequisite nor a necessary causative factor, but is interesting nonetheless that many of the adolescents and young adults do have exposure to these types of functional tic-like behaviors via social media prior to the onset of their own symptoms. So why is this occurring during the COVID-19 pandemic? I think, as many of us are aware, there's many stressors going on in society related to the pandemic. And some of the stressors that may occur for adolescents include school and extracurricular closures, the academic pressures of virtual schooling, especially when it was intermittently online and in person, and increased familial tensions during lockdown. For adults, if they have children, there's some of those stressors, but in addition, there may be job insecurity, heightened substance use, social isolation, and increased domestic violence that have occurred during the pandemic. And according to CAMH, the pandemic has heightened mental health symptoms and a demand for associated services here in Canada. So Dr. Pringsheim here is pictured doing an interview with Medscape Neurology about the social media influence of TikToks and how that may be related to this surge of functional tic-like behaviors, given that many of the adolescents and young adults did endorse social media exposure to individuals showing similar symptoms prior to their onset. And so functional tic-like behaviors likely are a very multifactorial illness presentation. This is a chart from the initial case series by Dr. Pringsheim and others from 2021, which shows that there are many different factors involved in the likely presentation of functional tics, including potential predisposing traits of genetic and epigenetic factors, interoceptive awareness, social cognition traits, and previous life events, including adverse childhood events. During adolescence, there are many psychosocial stressors, many exacerbated by the COVID-19 pandemic, including social isolation and online schooling. There may be physical stressors. And then, as we spoke about, the exposure to tics and tic-like behaviors through social media or other sources. Additionally, if there's a predisposing state for developing anxiety or depression, we did see that this is more comorbid in the functional tic-like behaviors. And additionally, any novel behavior that has behavioral reinforcement may continue to be perpetuated. And so there may be relation to behavioral reinforcement and social rewards related to tic-like behaviors and the sick role. So what was found in Calgary at the 6-month follow-up for adolescents and adults with functional tic-like behaviors? So just a bit of background. In 2021, Dr. Pringsheim and Dr. Martino published 2 case series of 20 adolescents and 9 adults with the rapid onset functional tic-like behaviors referred here in Calgary. All 29 patients were seen by one of these 2 physicians who are movement disorders neurologists, and a Yale Global Tic Severity Scale was completed initially and at a 6-month follow-up appointment. A paired t-test was then used to compare scores between the 2 appointments, the initial appointment in the case series and the follow-up 6-month appointment, for which I'll be discussing the results today. Ethical approval was received by the University of Calgary Conjoint Health Research Ethics Board. And the purpose of our study was to report the trajectory and the course of illness after 6 months of follow-up and the response to any medication or behavioral intervention that occurred during that 6-month period. And so for the results of the adolescents, there were 20 adolescents total, 19 of whom were assigned female at birth, 1 was assigned male at birth, 11 identified as cisgender, and 9 as trans, non-binary, or gender fluid. The mean age at the first visit was 14.3 years of age, and comorbidities included 25% with ADHD, 5% with OCD, 75% with GAD or panic disorder, and 55% with depression. 15 adolescents of the 20 returned for follow-up. 5 were lost to follow-up, but that included 1 individual who reported no further concerns of tic-like behaviors as their reason for not following up, which is a good prognostic sign. We did find that there was significant improvement at the follow-up in motor tics, vocal tics, total tics, and the impairment in global score on the Yale Global Tic Severity Scale. And there was a mean decrease of 31.9 points. 7 adolescents actually had impairment scores of 0 at follow-up, and 2 had total global scores of 0, meaning no tic-like behaviors were occurring at that juncture. The most often used treatments were SSRIs and CBT for anxiety or depression, which was comorbid. And in terms of other functional symptoms that may have occurred, there were 2 adolescents who did develop psychogenic non-epileptic seizures during the follow-up period. And when it comes to the results for the adults, there were 9, 8 of whom were assigned female at birth, 1 was assigned male. 7 of these individuals identified as cisgender and 2 identified as trans. And the mean age of the first clinical visit was 19.9 years. And thus we can see that this is truly a young population still, even though it's older than the typical onset for Tourette's disorder, we're still looking at young adults as well as adolescents with a mean age of 19.9 in the adult sample. The comorbidities here included 22% with ADHD, 0% with OCD, 56% with GAD or panic disorder, and 44% with depression. And while there was a decrease in the motor, vocal, and total tic scores on the Yale Global Tic Severity Scale from the initial appointment until 6-month follow-up, it actually was not statistically significant. Impairment in global scores on the YGTSS were significantly lower at 6 months, and there was a mean decrease of 19.5 points. There were 3 adults with Yale Global Tic Severity Impairment scores of 0, and 1 had a global score of 0. The most often used treatments were SSRIs and CBT, as well as adjunct antipsychotic medications for mood stabilization. And this was to treat comorbid anxiety and depression. And again, there were 2 adults in this sample who developed psychogenic non-epileptic seizures during the follow-up period. And so a summary of the results of our study and a discussion about where we go from here. Adolescents overall had better outcomes than adults. Despite both groups having improvements, it was only statistically significant with the adolescent group. And this is consistent with previous literature saying that the prognosis in functional neurologic disorders tends to be better for younger individuals. In that same literature, there is a reported favorable outcome for those who have early diagnosis and treatment rather than those who spend a significant portion of time not diagnosed with a functional neurologic disorder. And success was found in our clinical experience to be related to the treatment of comorbid anxiety and depressive symptoms, predominantly with SSRIs and CBT. As we mentioned, there were some adjunctive antipsychotics used in the adult population. The other behavioral component of what we would recommend for treatment typically would be a functional behavioral assessment and a comprehensive behavioral intervention for tics or CBIT treatment. These could be effective treatment strategies in tics and functional tic-like behaviors. This is the CBIT program comprises of similar information as habit reversal therapy. And so these could be effective treatment strategies. However, access is quite difficult as there's not a lot of availability of practitioners who complete these types of behavioral therapies, even in urban centers in Alberta, as well as any who are available are often not publicly funded. And so there's many barriers to accessing these behavioral therapies for both tics and functional tic-like behaviors. It's also important to have self-awareness about what the triggers for tics are. And for many of the individuals included in this study, that was inclusive of social media use. And so managing exposure, if it's a known exacerbating factor for symptoms, would be important. And so moving forward, this is likely to be an ongoing phenomena that we're seeing, at least at this juncture. Since the initial case series publications, there have been over 60 or approximately 60 more referrals to the movement disorders clinics in Calgary related to rapid onset functional tic-like behaviors. And so for the general psychiatry realm, what's important to know if you see someone who you think is meeting the criteria for a functional tic-like behavior based on a lot of the characteristics we described that would differentiate somebody from a typical Tourette disorder, What the best course of action would be referral to a movement disorders clinic or a neurologist specializing in movement disorders. As mentioned, those who have earlier diagnosis and treatment tend to have more favorable outcomes for functional neurologic disorders as a whole. And so referral to the clinic would be most beneficial. But additionally, the psychiatric side of things includes treating the comorbid mental health conditions, which for functional tic-like behaviors is predominantly anxiety and depression. And so utilizing our CAN-MAT and anxiety guidelines to try and use first-line agents for treatment of these comorbid conditions is likely to have good outcomes, including SSRIs and CBT, as we've seen in our patient populations. Additionally, psychoeducation, which can be provided with the neurology team, but also with the psychiatry team about what functional tic-like behaviors are and how the interplay between mental health, social influences, and the symptoms that these individuals are experiencing occur would be very beneficial. And if able to access CBIT, that would also be a likely effective behavioral strategy for these patients. So that's my talk on functional tic-like behaviors. Thank you for attending, and please check out some of the other resources I'll have available on the page for my presentation. Thank you.